Hello everyone. Today's topic is dermatomes and myotomes. We will look into it a very quick view. So, why are dermatomes and myotomes are important to us? We will look in. Mainly, the dermatomes and myotomes is required mainly for us, the physiotherapist, is to localize the spinal nerve root lesions, and we mainly need to differentiate between if it is an upper motor neuron and a lower motor neuron pattern it has, and to identify radiculopathy earlier, and to guide for the physiotherapy planning as well as the progression. So, what are dermatomes? We will look in. Dermatomes are the skin areas which is supplied by a single spinal nerve root. It is supplied by that of a single spinal nerve root is supplying that of an entire skin area. So this is the visual representation of dermatomes. You can see how it is being represented. The different colors represent the different regions it being supplying. So, the principles of dermatomal examination is we have the test of light touch as well as the pinprick sensations, and to mainly compare between the left versus right we look for in the of examination. So the dermatome key areas we have from C3 to S1, we can remember this, which remembering it would be easier for during the examination. It would be easier if we remember the sequence of this. So what are myotomes? Myotomes means it is a group of muscles which is being supplied by a single spinal nerve root. This is the group of muscles supplied by the single spinal nerve root is what it is called as myotomes. So how we are going to do a myotomal testing is to test for the isometric contraction. We hold for 5 seconds, we check for fatigue in the patient, and we compare the side to side. If it is right and red, we compare each other, and we use standardized patient positions to compare and to do the test with the isometric contraction. So upper limb myotome chart we have, that is for C5 to T1. C5 we go for shoulder abduction. C6 is for elbow flexion and that of wrist extension. C7 is for elbow extension and wrist flexion. C8 is for finger flexion and T1 is for finger abduction. And the lower limb myotomal chart, L2 is for hip flexion, L3 is for knee extension, L4 is for ankle dorsiflexion, L5 is for big toe extension, and S1 is for plantar flexion plus eversion. And why it is clinically important and how we are going to interpret it means alpha radiculopathy means there would be a weak big toe extension and dorsum foot numbness. This is the clinical features which we can see, and we can interpret that it can be a alpha radiculopathy. And if there is triceps weakness with reduced triceps reflex, we are going to get, if during the assessment means, we can assume that the patient may have C7 radiculopathy. Further investigation we need to confirm the diagnosis. So difficulty in heel raise plus there is a sensory loss in the lateral foot means there is S1 involvement, and weak brachioradialis plus that of thumb numbness is present means it can be a C6 lesions. So the red flags we need to remember here is that if the patient has progressive weakness, if there is saddle anesthesia between S2 to S4, and if there is loss of reflex plus rapid muscle wasting is present, bowel bladder changes is there means we need to go for an urgent referral. So to summarize, dermatomes is mainly for the sensory mapping and myotomes is for motor mapping. And we always compare the sides between left and that of right, and we think root level and not that of a muscle level. Okay, we need to always think about the root level. This is what we focus on. Yeah, thank you, and subscribe to my channel for more physiotherapy related topics.